What is TECVAYLI?
So TECVAYLI is the recently approved bispecific antibody for multiple myeloma, also known by its generic name Teclistamab. It's a class of medications called a bispecific antibody. For those conventional antibodies like daratumumab and elotuzumab, they attract a part of the immune system called the innate immune system to come and kill the multiple myeloma cells. What bispecific antibodies do is instead of attracting the innate immune system to the myeloma, they attract T cells to the multiple myeloma, which is another arm of the immune system. And what we've learned through the CAR T cell story is that T cells seem to have more potency in their ability to kill multiple myeloma cells than the innate immune system.
What is the mechanism of action of TECVAYLI? How does it work?
And so in order to engage T cells, these bispecific antibodies are reconfigured so that they don't just recognize the myeloma cell, but they also recognize a T cell. So you can think about a bispecific antibody as having two arms that are going to, you inject the bispecific antibody into the body. One arm grabs a myeloma cell, one arm grabs and activates a T cell and forces the T cell to recognize the myeloma cell, and then the T cell kills the multiple myeloma cell.
Who can receive TECVAYLI?
Right now, teclistamab is approved by the FDA for patients with multiple myeloma who have had 4 or more prior lines of therapy. And I believe the approval also specifies some particular therapies that they have to have had in the past, like an immunomodulatory agent, either Revlimid or Pomalyst, a proteasome inhibitor like carfilzomib or bortezomib, and an anti-CD38 antibody like daratumumab or cetuximab. And so that's the group for whom it's approved right now.
Can a patient receive TECVAYLI in the clinic if they have tried a few IMiDs, proteasome inhibitors, and an anti-CD38 monoclonal antibody but haven't had 4 lines of therapy?
So when the FDA approves a medication, they say who they approve it for. Physicians still have license to prescribe the medication outside the strict confines of that guidance if we think it's in the best interest of the patient once the drug is FDA approved. Now, we always have to do that very carefully, right? And after really considering the patient's individual circumstance when we're prescribing outside of what the FDA's guidance is. But for exactly the reason I was explaining before about lines of therapy, there are some patients with multiple myeloma who have only maybe had 3 prior lines of therapy, but are still out of options because in those 3 lines of therapy, they have received all the major effective medications. And we think that those patients should be eligible to consider a therapy like teclistamab. And so we are free to prescribe it, but where it becomes a conversation is a lot of insurance companies will restrict what they approve reimbursement for what the FDA has said is the population, the criteria. And so that's where some of these, oftentimes physicians have to have a discussion with the insurance company, things like peer-to-peer review, where we can explain some of this reasoning to the insurance company. And oftentimes, and I would say most of the time, they're receptive if we're doing this in a reasonable way to those discussions.
What trial was used to confirm FDA approval?
And so that clinical trial, the published trial, had 165 patients in it, and what we found is that most patients responded. I think the exact percentage of patients that responded was something like 60 to 65% of patients responded. Most of those responses were very good partial responses or complete responses, meaning that patients had at least a 90% reduction in the amount of myeloma in the body as measured with our blood tests. And those responses lasted a long time. And so if you look 12 months after starting the medication, about 70% of the patients, the medication was still working for them.
What are the major side effects of TECVAYLI?
The major side effects are cytokine release syndrome, neurologic toxicity, low blood counts, and infection. That clinical trial also told us about some of the risks with the medication. And I would say there are a few risks to be aware of that we learned about in the trial. So one is cytokine release syndrome, and this is an inflammatory reaction that happens in the body as T cells are activated against the myeloma. Most patients had high fevers as part of that cytokine release syndrome. We know from the experience with CAR T cells and even a little bit with the teclistamab that CRS or cytokine release syndrome has the ability to progress beyond fevers to include low blood pressure, difficulty breathing. And even if you look across all patients who have been treated with drugs like teclistamab and CAR T cells, there's even potential for cytokine release syndrome to be fatal. So you have to be aware that's a potentially serious toxicity. But in the vast majority of patients on the teclistamab study, that was a manageable side effect that could be handled either just by watching them closely or providing some supportive care, or in about, I think, a third of patients or about half of patients who had cytokine release syndrome required a medication called tocilizumab, which calms down that inflammation and allows you to continue with dosing. So that's one main risk to be aware of that we learned about in the study. The other is neurologic toxicity. And so as the immune system gets activated against the myeloma, for some reasons we don't totally understand, that can sometimes affect how the brain works, and patients can have something called ICANS. It stands for Immune Effector Cell Associated Neurotoxicity Syndrome. And these are a group of neurologic toxicities that can happen usually in the early period after you start this medication. And the actual manifestations are various. They can be things like tremor, difficulty concentrating, difficulty with motor tasks like writing, confusion. In more severe cases, it can progress to decreased consciousness, so difficulty arousing to like verbal cues, talking to people. And in the most severe cases, coma and swelling of the brain that can be potentially fatal. So that's ICANS. It can be seen after all of these T-cell engaging therapies like CAR T-cells and bispecific antibodies. And that happened in a few patients on this trial, but it was most cases low grade and manageable. But you have to be aware, though, that this is a potentially serious toxicity. Separately, there seemed to be another group of neurologic toxicities that have been seen in the different immunotherapies for myeloma that target BCMA. And I think these neurologic toxicities are different from ICANS because they generally have not been seen in with immunotherapies that don't target BCMA. So maybe something about targeting BCMA. One of them is a type of peripheral neuropathy that goes by different names. Some people say Guillain-Barré syndrome, some people say CIDP. But this is an autoimmune problem where the immune system gets activated against the peripheral nerves. It can cause problems like weakness. There are some other neurologic toxicities that have been seen with other CAR T cells targeting BCMA and bispecific antibodies that we're going to be on the lookout for with teclistamab. Like, for example, with Carvykti, the CAR T cell targeting BCMA, there's this more concerning neurologic toxicity that looks like Parkinson's disease that hasn't been reported with teclistamab, but I think we're going to be watching for it as more and more people are treated, just because we think it might be something related to BCMA. Likewise, Carvykti has this unusual problem where it can cause certain nerves to stop working. Like, for example, one of the facial nerves you can get like weakness in one side of your face after due to dysfunction of one of those nerves after Carvykti. We'll be watching for some of those side effects with teclistamab and some of the other bispecific antibodies that are being developed against BCMA.
How is ICANS managed?
So ICANS is primarily managed with steroids, and in the case of teclistamab, with just holding the medication until it resolves. And because they're happening after those small doses, usually you can kind of take them a little bit at a time. Small dose, you get a little cytokine release syndrome, let it pass. Second dose, a little bit more maybe. Those side effects tend to happen in the first, couple doses of the drug. As you get further into therapy with the drug, we start worrying a little bit about blood counts. And so most patients on the study had some drop in blood counts after they came on the study. Anemia, thrombocytopenia, low white blood cell count. That typically could be managed in some cases with transfusions, with giving medications to boost the white blood cell count like filgrastim or GCSF. That also tended to be something that was manageable over time. And then finally, I would say the big side effect or risk that we learned about with this medication is infection. So teclistamab does seem to increase risk of infection, and at least one way it probably increased risk of infection is by killing the normal plasma cells in your body. So remember, myeloma is a cancer of plasma cells, and plasma cells have a normal function in your immune system to help you make antibodies. So plasma cells are the main antibody-producing cells of the immune system. And a lot of the drugs that we use to treat multiple myeloma and kill myeloma plasma cells also kill normal plasma cells, and that's especially true of teclistamab and drugs like it. You really do kill off a lot of the normal plasma cells, and as a result of that, patients' normal antibody levels will get very low when they're on teclistamab, and that probably increases the risk of infection. And so one way we can help with that is to give patients antibody replacement therapy. So just like we can give red cell transfusions when your red blood cell count's low, or platelet transfusions when your platelet count's low, we can give antibody transfusions when the antibody levels are low. And we call that intravenous immune globulin. And it's not quite like a red cell or a platelet in that it's not from one particular donor, but IVIG is a formulation of antibodies that's collected from many, many different donors, purified down into kind of a drug, and then given as an IV infusion to a patient who needs it. And that can get the antibody levels back up in the healthier ranges for our patients. And that's something we do for regular myeloma therapy with some frequency, but it seems like most patients that get teclistamab will require IVIG or intravenous immune globulin to keep their antibody levels up. Now that we think does reduce the risk of infection, but doesn't completely eliminate it. And there's probably other ways that teclistamab affects the immune system that can't be completely remedied just with these antibody transfusions. And so that's why we have to just be very vigilant about infections. We are going to recommend that our patients on teclistamab get some prophylactic antibiotics. And so they should get prophylactic antibiotics against herpes viruses and shingles with a medication like acyclovir or valacyclovir or famciclovir. And we think patients should also get prophylaxis against a particular type of pneumonia called pneumocystis pneumonia. And the most common way to do that is with a drug called Bactrim, which is a conventional antibiotic that's used for a lot of different infections. You can take one dose of that 3 times a week and get very, very effective prevention of pneumocystis pneumonia. We recommend that all our patients stay up to date with their vaccines, including their COVID-19 vaccines, following the latest guidance, which tends to change every few months about which vaccines you should get. Now, patients on teclistamab will not respond as well to vaccines. Remember, vaccines are to induce your own immune system to recognize a bug, and part of the immune system is going to be disabled by the teclistamab. So patients that get teclistamab are not going to make antibodies in response to vaccines. But there are still other parts of the immune system, like the T cell part of the immune system, that probably can respond to the vaccine. So even though you're not going to make, for example, if you get a COVID vaccine, you're not going to make good COVID antibodies while you're on teclistamab, you might still make good anti-COVID T cells. And that's still worthwhile, therefore, to get the vaccines while you're on teclistamab. And for our patients who get COVID-19, all our myeloma patients who get COVID-19, but I think especially patients on immunosuppressive therapies like teclistamab, be very proactive about giving them antiviral medications if they can take it. So Paxlovid is really important. And we have seen patients have a little bit of difficulty eradicating COVID-19. We've still had some patients who have kind of a prolonged syndrome where they have trouble clearing COVID after they contract it. And so we still think of that as a real risk with this medication.
Additionally, TECVAYLI can cause liver problems. Increased bilirubin and liver enzymes in your blood are common with TECVAYLI and can also sometimes be severe. These increases in liver enzymes can happen with or without you also having CRS. Your healthcare provider will monitor you for these problems before you start and during treatment with TECVAYLI. Tell your healthcare provider if you develop any symptoms of a liver problem, including tiredness, loss of appetite, pain in your right upper stomach area, dark urine, yellowing of your skin, or white part of your eyes. Some people taking TECVAYLI can develop symptoms of an allergic reaction that can affect your whole body and may include fever or a swollen tongue. Injection site reactions are common with TECVAYLI and can include redness, heat, swelling, bruising, bacterial skin infections, discomfort, blood collection under the skin at the injection site, and rash. The most common side effects of TECVAYLI include fever, pain in your joints and muscles, back and chest muscles, and in your arms and legs, tiredness and weakness, upper respiratory tract infections and pneumonia, nausea, headache, diarrhea. The most common severe abnormal lab test results with TECVAYLI include decreased white blood cells, red blood cells, and platelets. These are not all the possible side effects of TECVAYLI. What everyday precautions should individuals on TECVAYLI take?
So I mentioned some of the medications like acyclovir and Bactrim, vaccines. Now, in terms of lifestyle precautions, I mean, this is the million-dollar question and the moving target, right? And this is really, I would say if it weren't for COVID-19, we would not be suggesting anything. You know, all our patients on myeloma therapy are at some increased risk of infection, but they live their lives, and that's a manageable risk, and we don't suggest people lock themselves down, maybe take some precautions to avoid somebody that you know is sick. With COVID-19, that's a little bit different, and obviously we all have these conversations all day long in clinic as patients want to know things that they can and can't do, and this really has to be individualized decision-making. Some patients will want to take more risk, others not so much. I would say that we know that behaviors and activities that increase risk. So number one, masks are really effective at preventing transmission of COVID-19, and so I've been telling my patients that on teclistamab or not on teclistamab, if there's something you really want to do, if you can do it with a good mask, it's very safe. And if you can do it with an N95-like mask, even if it's a crowded place, it's a very safe thing to do. What gets dicier is some of the gatherings and activities where you can't wear a mask, like restaurants and things like that. And that you have to just take your chances and decide if you want to bear that risk or not. I would still say with all the risk we worry about with COVID-19, even our patients on Teclistamab, most of them these days who are getting COVID-19 are recovering from it. But there is still, I think, an increased risk of severe complications or prolonged infection in patients in general with relapsed refractory myeloma, and I think specifically on Teclistamab.
How is TECVAYLI administered?
Teclistamab is administered as a subcutaneous injection in the belly, typically. I think the prescribing information also allows it in the thigh, but most of the patients in our experience receive it in the belly as a subcutaneous injection.
What is step-up dosing, and why is it needed?
So those toxicities I mentioned before, like cytokine release syndrome and neurotoxicity, these are generally toxicities that are seen just with the first couple doses. And as a result of that risk with those first couple doses, the study implemented some measures, and the FDA approval implements some measures to reduce the risk of severe complications. And so one of them is the step-up dosing. We think that by giving the dose initially as a small dose, and then a couple of days later a medium dose, and then a couple of days later the full dose, we can kind of ease in to that risk of toxicity instead of kind of activating the immune system all at once with one big dose. And those initial, what we call step-up doses, are recommended to occur in the hospital because some of those toxicities that develop, the high fevers, the low blood pressure, the difficulty breathing, they can sometimes happen in the middle of the night. And the best way to handle those if they develop is to have kind of the resources of a hospital around. But if things go smoothly, you can get in and out of the hospital in about a week after getting this medication and then resume the rest of the treatment in the outpatient setting. In terms of the types of centers that are going to be able to do this, so because of these particular risks of cytokine release syndrome and neurologic toxicity, the FDA has instituted for this drug what's called a Rems program, which is a special set of trainings that prescribers and institutions have to go through in order to be able to legally prescribe the medication. And so the physicians ordering the medication have to be certified in this Rems program. The hospital and the institution that's giving the medication and the pharmacy has to be credentialed in this Rems program to be able to give the medication. So it's a little bit of paperwork and bureaucracy and a little bit of training, but I do believe, though, that this is well within the capability of community hospitals and practices to handle. Most of the toxicity was low grade and it's manageable. There just has to be that process has to go forward before those places are going to be able to start the medication. At least in our network here, I think what will happen a lot is that we'll maybe start the patient on the medication at the subspecialty center, but then once you get beyond that first month or two of dosing, transition patients back to their local oncology offices to get the continuation dosing that they can just do in their office without necessarily having to link with a hospital that's been set up to give those initial doses.
What is the schedule of TECVAYLI after step-up dosing is completed?
So the way it's dosed after you get through those first couple doses that are in the hospital is once weekly subcutaneous injections. And the way the FDA instructions are written is once weekly subcutaneous injections indefinitely until the disease starts progressing. And I think in reality, we will probably experiment with less frequent dosing for patients who get into very good responses. And a little bit of that was done in the clinical trials as well. And I think we'll learn more about that over time. How long we need to continue that once weekly dosing. Can we back off to less frequent dosing? Can we even stop the drug in some patients? But we don't know all that yet. Will take some work to figure out. But the simple answer to your question is once weekly subcutaneous injections.
Are pre-medications given before TECVAYLI administration?
The pre-medication is really restricted to those first couple doses. And so there's some dexamethasone pre-medication. I believe there's also some Tylenol and perhaps Benadryl pre-medication, but it's really around those first few doses. And so this is not a drug where you're going to be getting weekly dexamethasone forever. It's really just around those first few doses, and that's to reduce the risk of allergic reactions and cytokine release syndrome.
Is step-up dosing needed if you stop TECVAYLI and then restart?
I believe the official guidance in the FDA prescribing information is if 28 days have passed since your last dose, that you should repeat that priming with the low dose, the medium dose, and the high dose. It doesn't necessarily have to happen back in the hospital, and it doesn't even have to happen on successive days the way you do it in the hospital, because at that point, presumably if you're taking a break like that, your myeloma is under good control. And so what we anticipate doing here is if we have a patient who goes more than 28 days, we would just bring them back for their next weekly dose and give this first priming dose. A week later, have them back, take the second priming dose. A week after that, go back to the first full dose. Not admit them to the hospital, but do that as an outpatient.
How long will it take to see if I am responding to TECVAYLI?
The response is, I think, apparent in most patients within the first couple months. Even if they don't meet that formal criteria for having a 50% reduction in the M spike or the light chains, it's kind of clear what direction they're headed very early if you check the numbers. For some patients in the hospital, we were very curious and kind of checking, labs even in between those step-up doses. We saw some patients even respond to that first tiny dose that they got. There are some people even at these very low doses that respond just to that very low dose.
Can an individual with previous BCMA-directed therapy respond to TECVAYLI?
If you've received prior therapies that target BCMA, you can still respond to TECVAYLI or Teclistamab. There are reports, it's basically a smaller number of patients that have been tested in this way that in clinical trials, but it does seem like a good portion of them responded.
Is there a TECVAYLI patient support program? Janssen CarePath is a patient support program. It offers different savings options and resources at no cost to patients to help them learn about, afford, and stay on their medication. It includes the Janssen CarePath Savings Program, Janssen CarePath account, and other helpful resources that are specific to each Janssen medicine. There is no income required, and you do not need to share your income information to participate in the Janssen CarePath Savings Program. Once you and your doctor have decided a Janssen medication is right for you, Janssen CarePath can help you understand your insurance coverage and out-of-pocket costs. We can also identify ways to help you pay for your Janssen medication and provide ongoing support. Visit myjanssencarepath.com to sign up.
Thanks for watching. By creating a HealthTree account, you can get exclusive access to the latest HealthTree University content, track your course progress, take notes, and bookmark lessons. Visit the links in the description below to get started.